Hi there. In this video, we are going to discuss about clinical aspects of neoplasia. Clinical effects of neoplasia depend upon multiple factors. For example, the location of tumor, the size of tumor, whether tumor is functional or non-functional, whether the tumor is ulcerated, whether the tumor has shown metastasis to lymph node or distant site, and so on. So basically, effects of tumor on a host are depending upon its location. For example, a very small tumor of the pituitary gland can destroy the remaining normal tissue of pituitary and can lead to the hypopituitarism. Moreover, the you can say leiomyoma of the renal artery can lead to the blockage of renal artery and can lead to the hypoxia of kidneys and can lead to the increased renin production and hypertension and so on. Moreover, the neoplasm, small neoplasm of the biliary tree can lead to the fatal biliary tract obstruction. However, the tumors of the ovaries, you can say, can grow to a larger size, as well as the tumor in abdominal cavity can grow to comparatively in larger size, and we will be showing little effect as compared to tumor at these critical locations. So location of the tumor is very important in determining the effects, clinical effects of the tumor. Moreover, the clinical effects of tumor also depend upon whether it is functional or non-functional. What does it mean? It means that it is producing hormones or it is not producing hormones. For example, a tumor of the beta cells of pancreas can lead to the increased production of insulin or insulinoma, and it can lead, when insulin production is increased, it can lead to the fatal hypoglycemia and so on. More of the tumor of adrenal medulla can lead to the increased production of catecholamines and can lead to the palpitations, increased heart rate, tachycardia, hypertension, and so on. Moreover, it also depends upon whether tumor has shown skin ulceration, which can lead to the bleeding, infection or not. And moreover, the tumors can also cause the obstruction of GI tract, which can lead to the multiple GI related problems. So location of the tumor, functional or non-functional status of tumor, or ulceration status of the tumor determine the effects of tumor. And moreover, you can add up here the extent of local disease, and metastasis are also important to determine the clinical effects of tumor on the host. So one more terminology we will study here is cancer cachexia, which is basically a condition which is shown by cancer or tumors. It is basically loss of body fat, loss of lean body mass, which includes the body proteins or muscles. So it is basically wasting of the body, and there is weakness, there is anorexia, loss of appetite, anemia. All these collectively called cancer cachexia. So loss of body fat, loss of proteins or muscles, weakness, anorexia, loss of appetite, and anemia. These are collectively called cancer cachexia, and it is basically due to it is not basically due to reduced eating. Instead, a normal person, if a normal person eating is reduced and there is starvation, body's metabolic rate, basal metabolic rate, decreases on. However, in cancer patients, basal metabolic rate is always high, regardless of whether patient is eating much or not. Mostly patients are not eating well. However, still their basal metabolic rate is increased. It is because our cancer cachexia is because of the tumor necrosis factor and other cytokines which are produced by tumor, as well as the inflammatory response to the tumors, and these cytokines and tumor necrosis factor lead to the cancer cachexia. They reduce the appetite, and they inhibit the lipoprotein lipase, which degrade the fats and release free fatty acid, and so on. So cancer cachexia is basically a condition whose there is no treatment except the removal of the tumor, the causative agent, which is the tumor. So when there is tumor or carcinoma, there will be cancer cachexia, and you cannot stop it unless the tumor is removed. Okay, so next we move on toward another terminology which is related to cancers or carcinoma neoplasm, which is paraneoplastic syndrome. So if a tumor is a functional, paraneoplastic syndrome basically is a set of symptoms which cannot be explained by local or distant spread of disease. How it means that the local spread of disease or the distant metastasis of disease does not explain the symptoms associated with a particular neoplasm, and it is mostly due to hormone or hormones related proteins produced by neoplasm. For example, hypercalcemia can be shown by different carcinoma cancers, for example, squamous cell carcinoma of lung or breast carcinoma. And this hypercalcemia is usually because they release parathyroid hormone related protein or TGF alpha, or they can also release the active form of vitamin D. And these proteins, or you can say hormonal factors and vitamin D, can lead to the hypercalcemia. So hypercalcemia is paraneoplastic syndrome, which is not due to direct, local or distant spread of disease. Instead, it is due to hormones produced by tumors or peptides or proteins produced by tumors, which lead to the hypercalcemia. Moreover, tumor also show Cushing syndrome, and this Cushing syndrome is commonly shown by small cell lung carcinoma, and it is because small cell lung carcinoma produces ACTH or ACTH like substance or proteins, and they lead to the increased production of cortisol and Cushing syndrome. So paraneoplastic syndromes are basically a set of symptoms which cannot be explained by local or distant spread of disease, and they are mostly occurring due to hormones produced by tumors. There are different paraneoplastic syndrome which are written here in the book. You can have an overview here. Important one are Cushing syndrome, shown by mainly small cell carcinoma of lung, other carcinoma showing pancreatic carcinoma, neural tumor, and so on. Hypercalcemia, it is shown by squamous cell carcinoma of lung and breast carcinoma. Polycythemia is important here. It is shown by renal carcinoma, cerebral hemangioma, hepatocellular carcinoma. So you should have acanthosis nigricans is important here. It is basically shown by gastric carcinomas, lung carcinoma. Gastric carcinoma here is important. Moreover, it is also shown in type 2 diabetes. So you should have an overview of different paraneoplastic syndromes from the MCQ's point of view here. Okay, next we move on to the grading and staging of cancer. So cancers are basically grading and staging of cancer is important because it helps us to determine the therapeutic effectiveness and therapies for the cancer. So what does grading mean? Grading basically refers to the extent of differentiation of tumor, and it means how much a tumor resembles to its you can say parent tissue. For example, if a tumor is arising from pituitary, so grading will show how much the tumor cells resemble with normal pituitary cells. So based upon grading, tumor can be low grade, which will be more differentiated, and high grade, which will be less differentiated. So having low grade means high differentiation, and high grade means low differentiation. So tumor having less differentiation is more aggressive, and tumor having more differentiation is comparatively less aggressive. It is basically an inverse response with differentiation. More differentiation, less grade, and less differentiation, more grade. So next we move on towards staging, and this staging is basically extent of spread of tumor, how much tumor have spread or increase in its own size. So for staging, most commonly TNM staging system is used. T here stands for the size of tumor, and N stands for nodal metastasis, and M stands for distant metastasis by hematogenous spread or lymphatic, mainly hematogenous spread here. So TNM is basically size of tumor. Depending upon the size of tumor, it can be T1 to T4, and T1 to T4 are different for different tumors. T1 to T4 are different for different tumors, and T0 shows in situ lesion. It means that this lesion is limited to the tissue itself. It has not crossed the basement membrane of tissue. However, when it will crossing basement membrane, it will not be in situ lesion, it will be T1, and when it will be increased more, it will be converted into T2, T3, and T4. And this classification T1 to T4 is different for different tumors, which will be which is given in the special pathology or systemic pathology. So depending on size, T can be T1 to T4, and T0 shows in situ lesion which has not crossed the basement membrane. N can be N0, 1, 2, 3, and so on. N0 signifies there is no lymph node involved, or cancer cells have not moved to any lymph node. N1 shows the lymph nodal involvement has occurred to one set of lymph node, and then N2 another set of lymph node, N3, and so on. So N2, 3, 4 shows the extent of nodal spread. And M0 and M1 shows distant metastasis. If there is no distant metastasis, it is M0, and if distant metastasis is present, it is M1. And the tumor showing distant metastasis, the M1 positive tumor, are mostly stage 4 tumors. So grading was according to tumor differentiation, and staging was according to the regional and distant spread of the tumor. Next, we move on toward diagnosis. How tumor can be diagnosed? For diagnosis of tumor, principal techniques used include biopsy. In biopsy, a small tissue sample of the tumor is taken and it is observed in labs for its histological characteristics, and tumors are diagnosed based on this, and this sample should be representative of tumor. FN is basically fine needle aspiration, in which through a needle cells of tumor are aspirated and they are observed for their characteristics, and it is also helpful in diagnosis of certain tumors. Next is cytological smear. It is basically cytological smear is basically collection of cancer cells from the fluids. So cancer cells are disc cohesive, or we know that they don't regulate the recadherin protein, due to which they fall in body fluids, and from these body fluids they can be observed in microscope, and it is basically used in the diagnosis of cervical cancer. Next is immunohistochemistry, IHC. We depend upon the tumor markers. We have previously studied some extent in the chapter, and in next systemic pathology there is also given that tumors have certain immunohistomarkers. For example, in Hodgkin lymphoma, CD15 and CD30 are the immunohistological markers, histochemistry markers, and they also help in the diagnosis of tumors. Next, there is flow cytometry, which uses the fluorescence technique and in the diagnosis of tumors. So these are the principal method of diagnosis of tumor. Next, diagnosis of tumor can also be done by molecular analysis, which is done by FISH and PCR technique. FISH is fluorescent in situ hybridization, only name is enough, and PCR is polymerase chain reaction. These two technologies are used in the diagnosis of tumors. They basically analyze the genetic abnormalities in the tumor. For example, different kind of translocations or point mutation present in tumors, or genetic disturbances are analyzed in the molecular diagnosis using FISH and PCR technique. They help in diagnosis of tumor. They help in finding out the residual disease after treatment. They help in the finding out the hereditary predisposition to particular tumor, and they also help in therapeutic decision for the treatment of the tumors. So it was all about the clinical aspects of neoplasia. Here are neoplasia chapter ends out. Thank you.